So this evening we have two things that we're talking about tonight. So we're going to talk a little bit about sepsis for the first half or so, and then talk a bit about just a couple of case reviews that have come up and have some good educational points along the way. Before we get going with that, does anybody have any pressing issues, anything from your home agencies, districts, regions that you'd like to bring up, talk about? Any recent calls or problems either encountered at the hospital or with the state or anything of that nature? Good. People feeling okay from the Ebola side? Seem to be kind of calming down a little bit and getting to a happy point, if you will. All right, we've been doing pretty well. I think essentially all of the three large agencies, Hanover, Hartford, and Leb, the three career agencies in the area that have graciously agreed to be the 911 transporting agencies for everybody that within the standard mutual aid region, if you will, have all kind of done their training, have been up to the hospital to do training up here from a decon standpoint and a patient drop-off standpoint. So I think we're actually pretty set. The other nice thing from this standpoint is that the way that the state and the CDC are running things at this point is that any patient that essentially is of any risk, i.e. a traveler coming back from Africa in an affected area, is being monitored. Those patients are being passed along to the states, the health department of both the state of Vermont and the state of New Hampshire. And those patients actually have very strict guidelines in terms of what to do if they were to become symptomatic within their monitoring period, and it is not pick up the phone and call 911. It is pick up the phone and call the health department, and the health department will then arrange appropriate transport for that patient, which again is not the 911 responding agency. For most of New Hampshire, it is DART, and for kind of our normal geographic region in Vermont, it is also DART, or it's FACT up closer to Burlington. So the chances that we're going to have an Ebola screened positive patient coming through 911 and activating one of your agencies is quite low. I wouldn't say it's zero, but it's quite low. That being said, both states have come up with a plan that if DART is being asked to go transport a patient from home back to Dartmouth-Hitchcock because they're a monitored patient and they've become symptomatic, febrile, whatever the case is. Local EMS is being contacted and is being asked to stage as either an extra set of hands if necessary, i.e. you have a non-ambulatory patient and DART needs help with extrication, or if there was an issue with the DART providers. You know, you're now, obviously not right now with the temperature being just about zero, but you know, it's a couple months from now. This is still going on, and you get kind of hot in that suit. They're working for a little while, and you have a medical emergency with a provider. We're looking to have some backup on scene as well, and we're hoping that the local agencies are going to be helping us with that. So that is kind of the Ebola update. We've had people in and around the area that have been through. We don't really have anybody right now. That's not true. I think there's maybe one monitored patient, a high-profile one from Dartmouth-Hitchcock that is still in the monitored period. But we're doing pretty well from that side of it as well. So, sir.
Can you yell? Fire engines outside.
I can certainly try that.
I've been in rudely parked their engine right next to the window. Yes, I did.
All righty. Any other questions? Issues? I don't think I have any other general announcements, so we might as well just jump right into it. So this lecture that I'm going to be delivering for the next hour or so is going to be a bit about sepsis. It is actually a lecture that was developed by Matt Roginski, who some of you may know. He's a third-year resident, one of the two chief residents for our emergency department and emergency medicine residency. Matt delivered the lecture this morning to the crowd this morning, and so I appreciate that. He helped me out as things were getting a little tight. So I don't know this lecture as well as I wish I did, but it is a good lecture, and we're going to talk a bit about it. All right, so who's heard of sepsis? Let me see. Raise a hand. Hopefully everybody. All right, excellent. So what's sepsis? Tell me. Oh, and standard disclaimer, right? Please speak up, bring up cases, issues, questions, throw stuff with me if I don't see you, and as interactive as possible, always makes it as enjoyable as possible. Heard?
Systemic reaction to infection?
Good, very good. All right, so we think, so I heard some sort of systemic reaction, I heard infection. Other things we think about? All right, good. So anaerobic metabolism, we'll talk a little bit about that as well. Other key words that pop into your mind when we hear the word sepsis? Very nice. Very fever, good. Very nice. What's that, Captain?
He's not being very nice.
I have to share an office with him. All right. So those are all very key words and points. So we're going to talk a bit about that. So I have kind of 5 take-home points that we're going to try to get to you tonight. And I think they're important for everybody sitting in this room, whether or not you are a advanced provider or a basic provider. So first and foremost, you have to think about infection for a lot of our patients, even if it doesn't quite seem like an infection right off the bat. All right? Because in order to recognize sepsis and actually do something about it, you got to be thinking about it. Just like anything else, right? To be able to diagnose an issue and come up with the problem, it has to be on your differential. It has to be on your list of possibilities. If it doesn't even make that list to begin with, you're never going to make the diagnosis. So remember, when you're seeing patients, keep your initial impression and your initial list of things that could be going on as broad as possible. Think outside of the box, and thinking about infection is going to be one of those. We're going to talk a bit about the importance of getting IV access and using that to give fluids, obviously. We're going to talk a bit about identifying abnormal vital signs and why that's important for this issue. Obviously, the fluids as a result of that IV access, and then why communication with the emergency department can be pretty helpful for these patients. So those are our 5 take-home points that we're going to reiterate throughout this lecture. So we said, what is sepsis? All right, so we heard systemic response, we heard infection, we heard fever, we heard anaerobic metabolism, we heard lactate. Those are all great things, and that actually kind of summarizes it pretty well. So when we think of sepsis, we very much think of a systemic inflammatory response. So you talked about that systemic response. And that inflammatory response is due to a multitude of chemical reactions at kind of the molecular level, if you will, that cause a significant amount of inflammation throughout the body. That tends to be a bad thing. It is as a result of infection. So we'll talk a little bit more. Lots of the signs and symptoms of sepsis can happen for other reasons that are not infection. What differentiates sepsis with those signs and symptoms versus something else with those signs and symptoms is the fact that it comes from an infection. And lastly, ultimately, all of this can lead to organ dysfunction, right? Sepsis is a bad thing. People die from sepsis all the time. What they're really dying from is kind of the end organ dysfunction, the organ failure that goes along and is the downstream result of sepsis. All right, so when we think about infections, where are some of the common infections that we think about that can cause sepsis?
UTI.
Good. So your bladder, right? You certainly have a urinary tract infection. Where else from a urinary tract standpoint? So you think about UTI, we often think about kind of the bladder infection. Good. And what do we call that type of infection in the kidneys? So if it's actually moved beyond upwards. So pyelonephritis is usually what we call it. Because nephritis, it cannot necessarily be due to infection. Throw pyelo in there, infection. So pyelonephritis would be kind of that kidney infection or a significant ascending urinary tract infection. Certainly just a straight UTI alone that doesn't necessarily even involve the kidneys can cause sepsis without a doubt. Where else?
Pneumonia.
Good. Lungs, right? Very much so. that's a classic one. You know, the little debilitated lady that doesn't kind of get up out of her bed very often, has a bad set of lungs to begin with, used to be a smoker, has some underlying COPD, doesn't clear her secretions very well, has been lying in bed with collapsed lungs because she's not mobilizing. That's a great setup for pneumonia, and that can get out of hand and cause sepsis. Other common places for infection?
Bowels.
All right. Yeah, so what do you, anything in particular?
Like an ischemic bowel or a blockage.
Yeah, so a lot of times you end up with kind of, you're coming with significant pain because of that, hopefully before you get to the sepsis point, but many times you don't. So you think about things like colitis or diverticulitis that's kind of getting on about. Any of those that actually cause a perforation of the bowel, that can certainly lead to a sepsis-like picture when you're kind of spewing feces within your abdominal cavity. That tends to be a bad thing and a good way to get sepsis. Very good.
Ready to burst.
Sure. So right. If you have any type of rupture of bowel, that's a great place. Most people that end up with appendicitis that is still contained tend not to be septic. They certainly can be, but they show a lot of the signs of that kind of feed into sepsis, and we'll talk a bit more about that. Other places for infection? Yeah, great. So we think about wounds like external. So skin is whether it's an infected wound that's been there, so the pressure sore, the bed ulcer that's been there, the guy that cut his hand on the dirty chainsaw, never cleaned it, and it's got a lot of organic matter, and now it's pussing out. The IV drug user that's been injecting and has a big abscess in their soft tissue. Yeah, the just terrible cellulitis in the debilitated person that is a diabetic, doesn't have feeling in their lower extremities, that banged their toe just walking up the stairs, doesn't realize that their foot is 3 sizes too big and a couple shades too deep of red. All of those can lead to systemic infections. Great. So we talked about lungs. That's a bladder, if you didn't know. We talked about the urinary tract and bladder being a source of infection. First look at this, it's a little bit difficult to say, but that is a belly button, and a big abscess with a surrounding area of cellulitis, right? So this is a pocket of pus underneath there, and if you push on it, first of all, the patient will kick you, but it'll be kind of fluctuant because it's full of pus, and all that surrounding erythema or redness is that spreading cellulitis from the focus of infection right in the belly. These are not, so who gets these right in the belly like that? Yeah, so diabetics that inject themselves with pumps. We'll see patients in the hospital, right? You get the little sub-Q heparin injections. So that's a kind of a common one. Good. We haven't mentioned this one yet, but your central nervous system. Kind of, again, thinking of other places that infections can live, the brain or the central nervous system can be one of those. So a meningitis is certainly something that needs to be on your differential, especially when you're dealing with kind of an altered mental status patient or a patient that's not acting appropriately. And there's a slew of kind of other ones. Still, you can really hide infection lots of places, but those are the big ones that we think about. Common things are common, and those are some of the common things. So thinking about sepsis and recognizing the septic patient is very much like finding that needle in a haystack. Now, you guys are pretty good. I'm pretty good. The emergency department's pretty good. If you have a really sick patient, it's not hard to know that you're a really sick patient, right? What's hard is to differentiate those patients that don't necessarily kind of slap you in the face and say, oh my God, I'm dying in front of you, right? There are a lot of patients out there that are actually quite ill that are tough to kind of get that flavor right away. They look a little bit better than perhaps their numbers do, than maybe some of their lab work does, and that can be more difficult to find. So that needle in a haystack kind of idea is still out there for sepsis. The really sick patients we get real aggressive with right off the bat. We know that. They're easy to kind of spot. When you have a blood pressure of 50, when you roll in the door, you know that this is a sick patient. But you got the patient, the little old lady that's got a blood pressure over 100, a heart rate of 95, who's acting a little funny, who you've never seen before and don't know what her baseline is, who's at a nursing home, and you got the night crew on that doesn't know her from the resident down the hall. That might be a tough patient to actually recognize that, boy, this patient might be really sick because she's normally hypertensive with a blood pressure of 180. She's normally, can tell you, can do the Sunday New York Times crossword. She's that sharp. And all of these changes are not her and are actually the manifestations of her systemic response to a bad infection. So, when we think of sepsis, when we think of people that get bad infections and get sick from their infections, who are we thinking of? So we talked about having this on our differential, having this for a lot of patients, but there are certainly patients that you should be more aware of that are at a higher risk for a significant infection. So what are some of those patients?
AIDS.
I'm sorry?
AIDS.
Great. So, and can you make that more general than that? Great. So HIV/AIDS are HIV actually. Having the virus alone, theoretically, yeah, you're probably at a higher risk. But depending on actually where you are in the process, if you've been classified as AIDS or not, whether or not you have actually a functional immune system still, that's kind of what it comes down to. So you may or may not be, but certainly if you're qualified as having AIDS, which is actually quite a distinct definition, your CD4 count needs to be at some point less than 200, or you need to have had a diagnosis of an AIDS-defining illness. Certain types of infections would be that type of illness. So AIDS, but in a more general classification, immunosuppressed or immunocompromised patients. So what are other types of immunosuppressed or immunocompromised patients? So HIV/AIDS, definitely. Good, transplant patients. Why are they immunosuppressed? Yeah, we make them immunosuppressed, right, on purpose. Otherwise, they're going to reject their organs. So they run around for the rest of their life immunosuppressed, either with significant anti-rejection drugs like Celcept or tacrolimus, or even something as simple as prednisone. Certain steroids will be used for immunosuppression with transplant patients. But steroids in general then. So the bad COPD that's on chronic prednisone, guess what? They're immunosuppressed. They're more likely to get ill, and when they get ill, they're more likely to get really ill. Good. Other patients that are immunosuppressed?
Chemo patients.
Excellent. Cancer patients, chemo patients. Again, often for the same reason. Sometimes if it's a blood-borne cancer, they may be immunosuppressed because they're not making the appropriate cell lines, or they're making too much of those cell lines, or they don't work appropriately. Often it's because of us, again, because of the chemotherapeutic drugs we're giving them. We kill their white blood cells. We kill the body's ability to actually fight off infection. So those are patients that are actually can get very sick from even very simple infections, right? I mean, you've all had the run of the cancer patient that spiked a fever. They look fine when you walk in the door, but they tape their temperature religiously like they're supposed to, and as soon as they cross a threshold, they show up in our emergency department because they are high-risk patients. Good. Other high-risk patients? Yeah, sure. So if you had to guess what type of patients we see the most of that end up with sepsis, old people are them, sure. So the elderly patients, very much so, much higher risk. So think about it with your old. What we often say, well, so we talk about, right, it's flu season right now. Flu hits the very old and the very young. Same thing, right? So those very young, infants, young children, neonates, boy, they're high risk for infection. Good. Others? Yeah, sure. Often because of some sort of kind of innate immunocompromised situation, often because their blood sugar, especially if they're uncontrolled, can be 200, 300, 400 routinely. Guess what loves sugar? Bacteria, right? They eat it up. That's what they want. And so if you have too much sugar floating around, boy, it's a nice little extra nutrient for for the bacterial infection that you're brewing. So we talked about the elderly. Bedridden, right? So now whether this is the elderly debilitated patient that's just can't move out of bed, or it's the younger patient that has the spinal cord injury and unfortunately can't walk or mobilize very well, all those can increase your risk. Infants we talked a bit about. Recent surgery would be something, right? So these patients, if they were just cut on, they've been exposed to not only the healthcare environment, their innards have been exposed to the environment, the air, all the bacteria around. There's multiple chances for contamination of that surgical wound and during the surgical process, and before and after the surgical process that place these patients at a higher risk. Indwelling catheters. What do we mean by that? Great, so Foley's are a classic one that we see a ton of, right? We send lots of patients home with Foley catheters. You have lots of old debilitated patients in nursing homes that end up with Foley catheters. They probably shouldn't be. Nursing staff and staff in long-term care facilities, boy, a Foley catheter is much easier to change than a bedpan or diapers, and that's why people will end up with them. But they breed infection. They're terrible for infection. They shouldn't be in there unless absolutely necessary. What else qualifies as an indwelling catheter? Yeah, sure. Any plastic in your body is an indwelling catheter, right? PICC line, central line, a Mediport, dialysis cath, right? If it kind of goes from external to internal, it's an indwelling catheter. And that's just a great way for bacteria to kind of creep up the outside of that catheter or the inside of that catheter and enter the skin, the bloodstream, or wherever that catheter is going. Steroids we talked about, transplant patients we talked about, and chemotherapy. Excellent. You got them all. All right, so I'm not going to dwell on the pathophysiology of sepsis. I'm going to talk, there's kind of just one general concept that is important. So normally you got your blood vessels, right? And you got your blood floating around your blood vessels. Your blood is made up of blood cells. It's also made up of kind of plasma or the liquid component of it. And your blood vessels do a pretty good job of containing your blood where it's supposed to be, within the blood vessels. As you get and develop an infection, as that infection gets worse and worse, and starts to cause this significant inflammatory response that goes along with sepsis, that inflammatory response, all those inflammatory markers and that inflammatory cascade and chemical reactions that are happening cause a disruption of the endothelial cells, kind of the cells that line the blood vessels. And they cause those cells not to work as well. They cause those cells to become more permeable and to essentially not contain the fluid as well. They cause it to leak. And so you start to, what people will say, third space, or you start to essentially move fluid from within your blood vessels where it's supposed to transport oxygen, nutrients, sugar, and whatnot, to your tissue elsewhere. So your soft tissue in your extremities, your soft tissue throughout your whole body, within your lungs instead of being within your bloodstream, within your intra-abdominal cavity. All this goes along with this. So, so what's the downstream result of that? So if I'm taking, if I'm taking, I get my 70% of my blood is kind of plasma or essentially the fluid component of it, and I start to leak that into my soft tissue, what's going to happen to my intravascular volume? Yeah, it's going to go down and it's going to result in hypotension. This is why septic patients are hypotensive. This is why their blood pressure sucks. So it's essentially you're trying to, and so when we're talking about treating sepsis, a lot of the initial therapy for sepsis is to kind of catch back up and refill the tank that is slowly leaking and continues to leak because of that permeability in those blood vessels. So you will hear this term, SIRS, Systemic Inflammatory Response Syndrome. And this is technically part of the definition of sepsis, but it can happen for a variety of reasons. So what is SIRS? Well, SIRS is two or more of the following things. Temperature greater than 100.4 or less than 96.8. heart rate of greater than 90, respiratory rate greater than 20, or a white blood cell count, which, unless you guys are running fancy tests in the pre-hospital field that I can't even run in my emergency department, a white blood cell count of greater than 12 or less than 4. SIRS is 2 or more of these. All right, so if you had a temperature of 102, your heart rate was 115, you're breathing 20 times a minute, and your white blood cell count is 25, you think you have an infection? Certainly can. Certainly can. What if I told you that patient doesn't have infection, they were just in a big MVC? Can they have a fever, a fast heart rate, an elevated white blood cell count, and an elevated respiratory rate? Yeah, they can. So this inflammatory response actually happens for a variety of reasons. So you will see actually a ton of, significant trauma patients are a classic example of this. They often have the SIRS response. It's not usually right away, but the next kind of 24 hours when they're in the ICU kind of recovering or hopefully recovering, they will show this huge inflammatory cascade. And they will, if you looked at their numbers, you would say, this guy's septic, this guy's got a terrible pneumonia or a horrible cellulitis or something's going on. But it's actually, these can all be results of the inflammatory response. The difference in sepsis is you have 2 or more of those and you have a presumed infection. All right, so the straightforward trauma patient that just got hit by a car walking across the street may have 2 or more of those. He's not septic, he just has a SIRS. He qualifies as SIRS, but not sepsis. But our little old lady that calls you for difficulty breathing, she's been coughing up a lung for the last week, she's febrile, she looks crappy, she's got a blood pressure of 85/40, she's septic. So I said blood pressure, right? But do you notice blood? Ooh. Oh. Do you notice blood pressure? Was that in the SIRS criteria? Right, and that's kind of part of the reason why you can have SIRS but not have it associated with an infection. How do we work blood pressure in? Well, blood pressure gets worked in because that's how you define shock, right? And so you can have sepsis but not be in septic shock. Septic shock is sepsis plus shock, low blood pressure. So we said you can have SIRS, we defined SIRS. You can have sepsis, which is SIRS plus infection. Then we can have septic shock, which is going to be SIRS plus infection plus a low blood pressure. And then, and so we qualify low blood pressure as systolic less than 90. And the other thing is, though, that there are other markers of poor perfusion, one of which is mental status. And so altered mental status is a qualifier for this, even if your blood pressure is over 90. If you have altered mental status, you have 2 or more of the SIRS criteria, and you have, a presumed infection, you are septic shock. This is showing a little bit better than it did this morning. So this is a fancy microscope of a capillary bed. And those kind of, the black lines that you see, those are capillaries, that's blood flow within the black lines. What is the difference between the top one and the bottom? Look at those black lines. Look at those capillaries. They're smaller. Exactly. So the top one is a well-perfused tissue bed. And the bottom one is a septic patient. This is actually, so these are the actual capillaries. You can see that they're smaller. They don't light up as much. They're kind of parts where you don't actually see them kind of connecting. That is poor perfusion within that capillary bed. That is poor blood flow. That is a result of that septic shock, that poor blood pressure not feeding blood and all the appropriate nutrients and specifically oxygen to that tissue. And so as we talk about sepsis and septic shock, as we talk about those capillaries becoming really leaky and not holding on to that fluid, causing the decrease in blood pressure, causing that our inability to actually perfuse and transport oxygen well to our tissues, the body also tries to sometimes kind of clamp down a little bit in some of these capillary beds, and that happens a bit more. But this is kind of a visual picture of what's happening within the tissue itself. You're just not getting the blood there. So early on we talked about, we kind of threw out different terms that we think of when we think of sepsis. Lactate came up. Anaerobic metabolism came up too. We talked about that last month maybe. So what is lactate? Oh, wow, Krebs cycle. I like it. I like it. You're absolutely right, right? So lactate or lactic acid is a byproduct of anaerobic metabolism. All of us sitting right here, presumably, are breathing pretty adequately. We got lots of oxygen in. We're offloading CO2. And our body and our cell is utilizing that oxygen to take glucose and turn it into ATP. The ATP is that kind of the energy that the cell uses. And so in doing so, the byproduct of that utilization of oxygen is carbon dioxide. So breathe in, oxygen in, breathe out, CO2 out. Great. But what if we can't get enough oxygen in? What if you're in an oxygen-restricted environment? What if you're working so hard you can't breathe fast enough and your heart can't pump oxygen fast enough to your tissues? Can your body still kind of produce energy to do what the cells need to do and to survive? Well, it can for a time. And instead of aerobic metabolism, instead of utilizing oxygen to take glucose to make energy, it goes through a different pathway, something called the Krebs cycle, where it does not utilize oxygen. This is not a preferred pathway. That's why your body doesn't do it all the time. And a result of that is that it creates a byproduct that is not helpful. If anything, it's harmful. It's lactic acid. So you still produce CO2, and you still produce, and you still get some energy out of it, not as much energy, and you're making lactic acid as well, this byproduct that your body still needs to deal with and get rid of. So if you're who's a runner or a cyclist? Oh, all right, Eric. So do you know what your lactic threshold is?
No.
Have you ever tested it? No. Okay. Do you know how to test? So what you'll find is some athletes who kind of train very scientifically will be able to kind of tell you, well, my lactic threshold is typically at a heart rate of 195, which is about 90% of my max heart rate, blah 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 blah. What you can actually do is, so your body's pretty darn good, and the more you train yourself, the more you can utilize oxygen, deliver oxygen to your tissues, and avoid the buildup and the production of lactic acid. That lactic acid causes issues with muscle contraction. That is why your legs ache after walking up multiple flights of stairs. That's why you are sore and tired after a hard exercise or physical activity of any sort. As you start to produce lactic acid, that becomes an issue. And then it takes a while to clear your lactic acid as well. And the better shape you are in, the quicker you can clear lactic acid. So if you're a very good athlete, or professional athlete that trains quite frequently, you can actually clear your lactate or your lactic acid very quickly, and you're ready for the next play, versus somebody that needs to really sit down and rest for 20 minutes before they can get up and actually start to function again. So you will see that. Now, so that threshold where you go from aerobic metabolism to anaerobic metabolism differs on everybody, and some people it's higher than others. And if you kind of train yourself appropriately, you can actually kind of increase that threshold and get closer to your max heart rate before you actually spill over to a lactate producing cycle. So why do we care about lactate in sepsis? That was all well and good for those of you that are training for the Olympics, but talking about sepsis. Good. We'll talk about that in a second. What was?
Easy to test.
Okay. And so how do you relate it to sepsis? How do you relate it to infection? Why do we develop it or build it up? Yeah, right. So So those leaky capillary beds that cause decreased blood volume, that cause decreased blood pressure, results in our decreasing ability to actually push oxygen to our tissue. Less oxygen to tissue means more lactate being produced and developed. So the lactate will build up. So the higher your lactate, the sicker those septic patients are. And so lactate is a great tool because it is easy to check. There are pretty straightforward standard blood tests that can check for it. I can get a result in 5 minutes in our emergency departments. EMS agencies can do it as well. It's within the protocol for Vermont and New Hampshire. If you want to go out and spend a couple $1,000s on a meter, it's essentially like an iStat or almost like a glucose meter, if you will, that will check lactate. And there are EMS agencies that are doing that. None of our EMS agencies that utilize DHMC utilize it. I know of 1 or 2 in the state that utilize it. We can talk about the pros and cons of utilizing it and whether it's worth the money. But lactate is an important thing because we talked about that little old lady that's a little bit altered, that's got a blood pressure of 110, that her heart rate's a bit elevated. She's not quite acting appropriately, but she doesn't look terrible. Her lactate may be 4. And so it's a huge red flag for us for hypoperfusion. And so it helps you find that needle in a haystack. That's why it's really helpful. So an elevated lactate is a bad thing. And typically when we're talking about elevated lactate, 4 is kind of that magic number. Above 4, you're pretty darn sick. Okay. Can you have elevated lactate for other things other than infection, other than sepsis and septic shock? Yeah, right. We said significant physical activity can do it. So that being said, what kind of medical call would you get that corresponds to significant physical activity?
Difficulty breathing.
Could be, right? So if they're working really hard, yeah, and they're, I'm sorry. Could be as well. Yeah. Hopefully not. Any type of hypoperfusion can certainly lead to it. Seizures, right? It's a nice little tool for us. If you have somebody that's seized, and you think they're kind of FOS, quick little check. You know, if their lactate's totally normal, most people that truly seized had a generalized tonic-clonic seizure. They're not breathing really well during that time period. They tend to get a little hypoxic, and they're going through significant muscle contraction. They end up producing lactate, and they typically don't clear it by the time they get to the hospital. So it's a nice little check for us. There are other tests you can do that are a little bit more sensitive to that, but that's one use for it as well. So there are lots of reasons why your lactate may be elevated. The terrible trauma patient, right? The hypotensive trauma patient, same thing. If they don't have blood volume, not because they're leaky capillary beds, but because they're leaky capillary beds, but because they're decreased their blood volume because they bled half of it onto Route 89, they're going to produce lactate as well. Yes, Joel?
Lactate being an acid, is there any correlation on these patients? Because we don't have iStats, but is there any that we can correlate it to exhale with pedals or what we've seen? That's the one thing we do have.
Yeah. The answer is yes, there's a correlation, but the end-tidal CO2 is probably not, in most cases, sensitive enough to kind of differentiate one versus the other. So one of the ways your body deals with that, yeah, exactly. So it tries to deal with the lactate and the acid by essentially converting it to carbon dioxide and getting it off via a respiratory cycle. That's one way of doing it. The other way is you dump hydrogen ions or that acid kind of component into your urine as well. And so you can kind of help balance your pH that way. Somebody mentioned pH before, so as this lactate builds up, your pH goes down. Right? The more acidic something is, your pH goes down. And as you get more and more acidic, bad things happen. Normal processes don't function as well. Muscle contraction doesn't happen as well. Myocardial contraction doesn't happen as well. Your blood doesn't clot as well. So pH is another marker of kind of badness, if you will, and it's often associated with an elevated lactate.
Can bicarbonate
Good question. And I'd say no one's not quite sure. So most people will say, they've tried this for a long time, right? It makes sense. You're terribly sick, you're terribly acidotic from your horrible sepsis. I can give somebody bicarb. I can dump a ton of bicarb into them and try to neutralize that acid within their blood, get them more to a regular normal pH. Does that actually help patients? What they find is most of the studies will say that those patients die just the same, if not more, or faster. And so most ICUs will not start bicarb drips for a sepsis and septic shock unless your pH is really low, like 6.9 or less. And even at that point, there's really no evidence that it does you a lot of good. It's kind of like throwing the kitchen sink at somebody. So how do we treat it, though? Good, good. So what do fluids do? We said fluids and antibiotics. Those are the two mainstays of treatment of sepsis. So what are we doing with fluids? Yeah, right. So we talked about that leaky capillary bed. We talked about that low blood pressure. We need the ability to deliver those oxygen carrying red blood cells to our organs to avoid this cycle, this anaerobic metabolism. So let's get more fluid into them. Let's pump them up with fluid. Great. Isn't that fluid going to just leak out? Yeah. It's going to continue to leak out. But, you know, it's kind of like you got to do something, right? You're trying to refill that tank to get things back to as normal as possible. And yes, you are going to continue to kind of third space some of that fluid. And so the fluid component of sepsis treatment is the first thing you do. And it's one of the most important things you do. It doesn't necessarily get to the root problem, though, right? So what's the root problem again? Infection. And how do we deal with infections? Usually antibiotics, or what we would call source control, right? So if you have an infected PICC line, guess how you control that source? You pull the PICC line, right? If you have an abscess on your belly, that's the source of your infection. How do you deal with that source? Yep. Open it up, incise it, drain it. Right, so source control and early antibiotics are how we address the infection. That's the underlying problem. The delivery and the treatment of giving them a ton of fluid just kind of buys us time till the antibiotics can start to do their thing and stop that huge inflammatory cycle. And once that inflammatory cycle starts trailing down, your vessels will start to hold more fluid, and you won't necessitate as much fluid resuscitation, and you kind of go back towards being physiologically normal. So how much fluid do these patients need? So do we have a sepsis protocol in New Hampshire? Yeah. Do we have one in Vermont? Great. What does it say? So how much fluid can a paramedic give in New Hampshire, or should give in New Hampshire? So, but that's absolutely right. You look it up, right? It doesn't matter. A lot is the answer, right? Give them a lot, and probably much more. The protocol actually can say says up to 4 liters. All right, and boy, if you can get 4 liters into most of our patients with our transport times for most of our agencies, you're pushing it. Good for you. But usually, you're going to bang them with a liter. Hang a second if you have a really hypotensive patient that you think is significantly septic. Don't be afraid of fluid in these patients. They need fluid. All right. Vermont is a little bit more gingerly. They say you can give, I think, 1,000, and then, or I think it's 1,000. You can go up to 2 or 3 liters if you call medical control or something like that. But in the end, these patients need a lot of fluids. Give it to them in boluses, right? Give it to them. Give them a 500 cc bolus. See how they do. Don't just hang 4 liters of fluid wide open on a couple pressure bags and push it all in and see what happens. They don't necessarily need all of that. Not everybody needs 4 liters of fluid right off the bat, but most septic patients, the current guidelines are, 20 to 30 cc's per kilo of fluid for both kids and adults. All right, so that's a fair amount of fluid. Most septic patients will take upwards of 8 liters in the first 24 hours. It's a lot of fluid. It's a lot of fluid, but they need it. They won't hold on to all of it within their blood vessels, but that's okay. You still need it to maintain your blood pressure, to maintain that perfusion, and to avoid those organs from starting to fail on you. Because if you don't perfuse those organs, those kidneys, the liver, the brain, the heart, they will start to fail, and you will end up with worsening problems, and it's just a vicious cycle, right? So, fluids, big one. So, basic providers, how do you deliver fluids? Pick up the phone. Pick up the radio. Call for that. You know, we think about calling for paramedic intercepts for, for trauma patients and for pain control and stuff. Think about it for fluid administration alone. For that little old lady that's probably got a bad pneumonia. She needs fluids, and the sooner we give her the fluids, the better. So think about that that ALS intercept. What we find is that many septic patients, close to half of them, won't actually get any fluid via EMS. If you look at the studies. And that's for a variety of reasons. You may have a real short transport time. Perhaps they're a tough stick and you couldn't get a line. But it's also a little bit of, sometimes these patients are, again, tough to notice, tough to identify. And so the trigger in your mind that this is a septic patient didn't necessarily go off. So keep sepsis and septic shock in your differential and think about fluids for these patients. All right. So get that IV access, give fluids, and don't be afraid. Vasopressors are kind of another mainstay of treatment for sepsis. Most of us around here won't ever get to the point where we're starting vasopressors. Typically, if you roll in with a bad blood pressure and I think you're septic, I'm not going straight to hanging norepinephrine or dopamine or epi. I'm giving you fluids up front. So, and that's the first and foremost. You need to essentially fail the fluid challenge, and you have to be adequately resuscitated via fluids before you're going to roll over to vasopressors. There are multiple pressors that are identified in both Vermont and New Hampshire in their protocols. First of all of them need to be used on a pump, so if you don't have a pump, you can't be using them. And most people around here carry dopamine, right? Essentially everybody around here carries dopamine. That was the pressor of choice, if you will. It kind of worked for all things. It's pretty good for cardiac and cardiogenic shock. It's okay for sepsis, or at least we thought it was. What we're finding now is there is a preferred pressor for sepsis, and it is likely Levophed, norepi. It is my pressor of choice if I had to kind of choose one pressor to have in my back pocket, because I think it works pretty well for close to everything. It is better for, it is better, it is the preferred choice for sepsis. Okay? And it's pretty darn good for cardiogenic shock also. Actually, I like it a little bit better than dopamine. I think it's a little less arrhythmogenic. I think it doesn't cause the tachycardic response that you get with dopamine. The one indication, does anybody know why you may choose dopamine? One indication where you would choose dopamine over Levophed? Any of the paramedics? Yeah. So that bradycardic patient, sometimes you want that tachycardic response that you're going to get a little bit more of with bradycardia, with dopamine than Levophed. That being said, I still think if you're going to choose one pressor to have on your rig, Levophed is probably that pressor, because you'll still get some of the effect from Levophed, and what you don't get from pressors for that bradycardic patient, or you can get with electricity. So you have an alternative, if you will. So pressors act by essentially causing vasoconstriction, right? Taking that tank, those blood vessels that have not only become leaky, but they actually tend to dilate as well. So now your tank, while you may have kind of held 8 liters of blood in your body, with the vasodilation of all those blood vessels, now essentially that tank holds 10 liters. That causes a drop in your blood pressure. This the vasopressor of your choice essentially kind of causes a constriction of those blood vessels to increase your blood pressure that way. Norepi or Levophed is the pressor of choice, is in the guidelines now. It's no longer consider this versus this. There is good evidence that patients do better with Norepi for sepsis. And antibiotics. This is kind of not for pre-hospital use up here at this point, but there are EMS agencies that initiate antibiotics pre-hospitally for a septic patient. And what we know from the in-hospital data, the emergency department data, the ICU data, is early recognition, early fluids, and early antibiotics is what saves these patients significantly. So early antibiotics, i.e. you giving it in the field an hour before the patient would actually get it in the emergency department, that makes a difference, and that's a real thing. So it may be somewhere in the future. It is there in certain jurisdictions, and it seems to be working pretty well. Communication to the ED is important as well. So we do this very well in our region. I think overall we do it for STEMI, we do it for stroke, we do it for trauma. We have these alerts. There are plenty of places, and we essentially have sepsis alert as well. Actually, the words sepsis alert are in the Vermont protocol. New Hampshire just says alert your ED that you have a septic patient. It doesn't matter whether you call it an alert or not, but if you're thinking sepsis, tell us, hey, I think I got a septic patient here. I got a 62-year-old female that's been coughing for a week. Sounds like she has pneumonia. She's hypotensive, tachycardic. She's got two lines. She's working on her second liter. We're 5 minutes out. Great. That prompts us, again, because early recognition and early delivery of these therapies is what saves these patients. So that extra 10 minutes for us to start thinking, or even for you to kind of just prime us and say, I think this is a septic patient, means that you may have 2 nurses at the bedside. We may get that extra line a little bit faster. We're going to get our lactate that much faster because we may get that blood draw a bit faster. And perhaps those antibiotics that aren't in the Pyxis because they were just used for the next patient, the call goes down to pharmacy and says, hey, restock us. We have another sick patient that might be needing those pretty soon. So that little notification, whether you think so or not, actually does help patients. So please do communicate with us. Share that valuable information that you collected. If you got what you think is a septic patient, say it. If you're wrong, you're wrong. I'm wrong all the time. No harm, no foul. So in the end, what you guys do in the field really matters for these patients. Recognizing these patients, getting IV access or getting somebody there that can get IV access, and early fluid administration saves patients. These patients do better with those things. A delay in any of those components means more patients will die from sepsis. It's black and white in the literature. It's really, really there. So please remember that. This is, there's a couple things that I really think that we make a difference in EMS with. This is certainly one of those. Patients die from sepsis a ton, and you guys can actually play a large role with helping prevent that. All right, our take-home points, right? You got to think about it. If you don't think about it, you're not going to diagnose this, and you're not going to go diagnose it, and you're not going to go down the right path. Get that IV access. Identify those vital signs, right? Is this SIRS? Do I have a hypotensive, tachycardic patient? Are they breathing fast? Are they febrile? Give that fluids, and please talk to us and get us prepped as well. Questions? All right. Well, that's my sepsis talk. Why don't we take 5 minutes, and we'll kind of come back and run some cases. Great. Thank you.
Yeah, yeah. Are you doing it? Yeah, I think so. Yeah. I don't know why.
next to your boots.
Yeah, I took it off your desk. And I got back to the easy stuff.
Oh, it was yours?
Yeah. We got this.
Pretty bad. I dropped my
I'll print some more. Need the paramedic one.
I think I took the wrong one, even though I'm not sure.
Yeah, they're all these guys too. They get different.
The categories are different. It's not a huge difference, actually.
Yeah, my goal is to at least. I'm gonna try to.
Happy New Year, man.
Sorry?
Bobby Boucher. What do you want? You gonna have him talk about your man? What about theirs?
So I have 3 or 4 cases that I just picked that I thought were interesting. If people have a case that they think is interesting and we want to discuss it as a group, come up now and we can try to find it real quick and then run through it.
There's nothing really to say about it.
No, I wanna know what the outcome was though. You wouldn't know if it didn't. What you said about lactic acid.
Okay. It only takes about 12 minutes. Like 12 minutes.
How does that? 4 milligrams.
It's after the 1st of December.
The 10th. 10th is ours.
You guys are on it.
Yes, sir.
Saturday night. Third, Saturday. Right, to Saturday, yes, just about 6 o'clock Saturday.
he goes unresponsive again. Given Narcan, takes up
Why don't we, we'll talk about it.
He's on the protocol subcommittee.
We did it 12 weeks.
Yeah, it was depression.
You guys have
Daily,
right.
So we'll talk about this one. You got one? A name would be.
No, it's the same. Theirs was on 12/1, ours was on 1/10. Same. No fingertips. Yeah. Just have the border. Are you okay?
We'll chat, thank you. Any other cases that people want to suggest for discussion? All right, why don't we get going?
Oh boy.
Stage 5. I know the name. Of course, you could double your calls. You take them there and then go back to the station and then get that straight.
Alrighty. So I'm going to go with a couple cases. I have, again, I have 3 or 4 that I picked that I thought were kind of interesting, and we have 2 that were suggested to take a quick peek at as well. So we'll try to kind of cram them all in here in the next 45 minutes. As usual, this is going to be quite interactive. If you have other cases or whatnot, that we can certainly kind of present those a little bit less formally. A couple things to remember. The cases that I've picked here are all from agencies in the Upper Valley region that utilize Dartmouth-Hitchcock as their medical resource hospital.
Or you can stand back here, that'll work.
And they're all patients that were treated here at Dartmouth-Hitchcock. These are not interfacility patients, transported patients. This is a quality assessment and quality improvement initiative, right? So this is protected by Vermont and New Hampshire law. What's important to recognize, though, is if you go outside and kind of start talking about this, it is no longer protected and it would be kind of violation of patient confidentiality, and any discussion regarding it at that point is no longer protected from discovery from a legal standpoint. So as always, please be respectful of what we're talking about. This is for educational purposes to make us all get better. Another couple things, right? So these case reviews are not necessarily anything wrong with these cases. Actually, I think they were just very interesting cases to talk about. But the purpose of this is really for education. We can always do something a little bit better. This type of review and the analysis of these cases gets done at every level of medicine. Okay, so whether you're an intern in the emergency department, a chief resident, a new attending, a senior attending, a section chief, all of our cases in hospital get reviewed on a pretty regular basis. And certainly any cases that didn't go as well as we would hoped definitely get reviewed on a regular basis. So we're not picking on anybody during this process. And you'll see that as we're doing more QA these days with the help of our EMS coordinators, and we're starting to feed that back to agencies, this is all just for education. We want to get people better. We want everybody to continue to improve. Most of the QA that we do, there's not necessarily anything wrong with the chart, and we try to kind of help you buff it up a little bit more just to give you some teaching points with it. But overall, good job. You know, most of the charts we show, we review are excellent, good care. Every once in a while we find little things that we would maybe tweak, and every once in a blue moon we'll find kind of an error that really should be addressed and talked about in a little bit more detail. Everybody makes mistakes. If you can make it, I've made it, right? It's okay. It's the practice of medicine. I know it's a difficult environment that we're in because we're not supposed to make mistakes, right? And unfortunately, they will happen occasionally. The important thing is to kind of recognize them, to learn from them. And the nice part about talking about it is everybody can learn from the one mistake versus everybody making that mistake over and over again. And so it's nice to kind of share those things. Hindsight is always 20/20. It's very easy for me to sit in my office, to look at a chart, to look at the patient's record in the hospital and say, boy, you know, how is this missed? Of course this is what was going on. It's very different if you're out in the field seeing a patient with kind of very little history, very little background, no significant ability to do further diagnostic testing. I recognize that, and so please recognize that as well. It's hard to do our jobs, and that's why this is not punitive. This is not to point fingers. This is not to make anybody feel bad. This is to get people better. All right, I'm going to kind of pop in and out of here. Captain Thibault, do you want to talk about your one patient real quick? Present it, and then we can just discuss it real quick? Sure. Go ahead. And if you actually speak loud, the room is mic'd as well, so we'll probably be able to grab it for the recording.
I feel like that was just payback, but so Hanover Terrace for a 60-something-year-old male who's unresponsive. We get there, the guy's sitting in a chair, and he is unresponsive. And they said that they received him the night before, and he's been in and out of consciousness. When he's awake, he's screaming, and when he's not awake, he's completely unresponsive. But we did sort of get him around to verbal. As we started to move him, he sort of was arousable to verbal. We get him in the back of the ambulance and trying to figure things out. We started a line, did a 12 lead, which was unremarkable. And
why the 12 lead?
History and the fact that we couldn't get their history and the fact that we couldn't get any symptoms. He's unresponsive. So
yeah, I mean, great, right? We don't do enough 12 leads. It's not they're all not only for chest pains, they're not only for shortness of breaths, the altered mental status, the unresponsive, they should be grabbing 12 leads as well.
And he was setting like in the mid 80s, so there was some potential shortness of breath. But also when we walked in, he was sitting in the chair. His airway wasn't really open, so that was the first thing we did was just tilt his head back. But in his huge stack of paperwork, he's got all kinds of problems. He's got this big liquid-filled belly that was like disturbingly distended, and he's got a vac dressing on his thigh, which was really the primary reason that he was there, and So we get him in the ambulance, we get everything, and we're underway, and he was sort of somewhat awake at that point. We're having a conversation about maybe it's an overdose, and he said, no, I'm not really on anything. And then maybe 2 or 3 minutes later, he went completely unresponsive again. So at that point, we gave him Narcan, and he sat bolt up. We gave him 0.4. He sat bolt upright, screamed, no, you gave me Narcan. And then he kept screaming until we left here.
Good.
We did have a fentanyl patch that we didn't find until we were bedside here. But
I'm sorry, this was like a skilled nursing facility? Did they provide a medication list that you were able to look through at any point? Did he list? Okay. All right. So, so altered mental status patients, especially our older patients, boy, we talked about that differential, right? The things that could be going on. So you got a quasi-responsive guy with a wound vac who's mildly hypoxic and in and out of kind of consciousness. What could be going on? Sepsis. All right. He's got a source, right? Definitely. He's altered. So if he had other service criteria, what would he?
check his temp and his sugar as well.
Okay, good. So temp was
Fine. Temp and sugar were both unremarkable.
all right. Good. So sepsis, definitely great, right? Because if he had the service criteria, he looked like he probably could have a source of infection, and whether he was hypotensive or not, his altered mental status would have pushed him into septic shock. Excellent, or the category of. Sounds like it was not sepsis. Good. You said you checked the sugar, right? Every altered mental status patient, every stroke patient, every seizure patient, get a finger stick. Every provider in this room can do that and should be doing that. Very good. All right, good. How so?
Just with altered mental status.
Good. So what's you're certainly right. It would be on the list of the differential. What is maybe a little atypical for a CVA in this guy? Yeah. So do most strokes lose consciousness?
They stay on treatment.
Well, yeah. So what's a classic stroke presentation? What's that?
Looking like you're drunk.
Okay, could be. So how so?
Kind of like the slurred speech.
Slurred speech, droopy face.
Last over dazed look.
Uh-huh. Good. All right. So, but they're typically not kind of unconscious, right? They may have weakness somewhere, one side of the body versus the other. And remember, most stroke patients. So how do you get that? So if I walk in with left-sided weakness, facial droop, and slurred speech, where's my stroke? On the right side. So remember, most stroke patients, almost all stroke patients, are having a single stroke, right? They flicked off. They sent a blood clot from their heart due to their AFib up through their arteries, or they finally kind of just blocked off a blood vessel within their brain, and you end up with a stroke in one focal location on one side of the brain. It takes, in order to lose consciousness with a stroke, you actually need to affect either both hemispheres or both sides of the brain, or you need to affect parts of the brainstem. Which tend not to be significantly, frequently affected, if you will, from strokes. It's possible. You can have something called Topolo-Baser syndrome. You can have a stroke in the RAS, the reticular activating system within your brainstem. That will cause you to go unconscious. But most other kind of ischemic strokes, you're affecting kind of one side of the brain or the other, and you will be conscious. You may not be appropriate. You may be aphasic or dysarthric and very much altered, but usually not unconscious. But you're right. And sometimes if he's just kind of nodding off and waking up, or is he truly unconscious, or is it just yeah. So stroke would be on the list of differential. What do you think? How do we treat for that here in the ED? Well, actually, how do we diagnose that or try to diagnose that besides physical exam? What's the first thing we do? CT. Yeah. What do you think this guy got? CT. Good. What else? List of things that could be going on with this guy who's altered with his kind of basic, so diabetic emergency. Well,
Alcohol, seizures.
good. So post-seizure, is he right? Is he post-ictal? Or is he having ongoing seizures? He meant, is he having non-convulsive seizures intermittently? You said, what was the other one?
Alcohol.
Good. Is it tox?
I think the thing to note is he knew what Narcan was and how it affected him. That should be a
It's a red flag, right?
yeah.
Very much a red flag. And it could be slapping you in the face, and oftentimes that is what is going on. Just remember, keep that differential, keep that list of other things. So when you address that, and you can easily address that for most of these, right? You can give them some Narcan, see what happens, and it doesn't work. You have something to fall back on. Is it something else? There could still be something else going on.
Multiple overdoses was sort of buried deep in the stack paperwork that they gave us. So we sort of found that like right after we gave him Narcan.
Yeah. How'd you give the Narcan? IV? Have people been given Narcan IN? Good response? Not so much? Like it? Don't like it? It's a little slower. You're finding yourself having to give more if you give it IN, or you just wait longer?
Like seconds, like 30 seconds.
Yeah. I mean, we don't. Our opiate problem around here is not as big as different parts of the state. It's still decent though. But IN Narcan, don't forget about it. It's a great little trick, even for advanced providers that can easily start an IV or give it IM. No reason to get a sharp out for this, possibly Hep C HIV patient that's drug abusing and is going to get violent on you in 2 seconds after you give them the Narcan. So, good. All right. Thinking tox, other things that you maybe would look on your physical exam that would make you think opiate overdose? Good. You remember were they? I guess we'll never know. Have a good one, guys. Thank you. Okay. So pupils, they said a little hypoxic to begin with. So looking at that respiratory rate, right? Are they hypoventilating a little bit along with that? If you're thinking more of less of a prescription drug abuse and more of a illicit drug abuse, looking for signs of IV drug abuse, track marks, abscesses, skin popping, that type of thing. There are lots of things that will go along with that. So good. Or just that heroin chic, 85-year-old cachectic person. All right. So that patient actually did come in, got kind of the full altered mental status workup, got their EKG, got their blood work, got their head CT, was quite combative, it sounds like, when they first hit the ED here. Was eventually, after kind of looking through everything, they also kind of were able to eliminate most of the other reasons why this patient might have been altered, and were left with the potential or the likelihood of over medication with their opiate medication. That being said, the patient ended up getting admitted because in that full workup, they ended up having some EKG changes and some other things pop up. That's probably not the reason why the patient was altered, but still bought them an admission, and they're still in-house. So, do you want to talk about your case real quick?
Yeah, 91-year-old female in the bathroom on the toilet. Came over as loss of consciousness, but she was just kind of logy in there. Bradycardic, 50s and 60s.
She was like 89.
PO2 in the 80s.
89, 90, 80.
Never really quite got back to snapping to it. We a lot of the things that we would otherwise try, we kind of had to. Getting her out of the bathroom, onto the gurney, and out of the house turned out to be block some of the things that the Windsor guys wanted to try. I guess they waited till they got her to the rig to do this. We never did find out what happened with her.
I wasn't on that call. I would other. She's offered.
All right. So
She was warm to the touch.
okay. So you paint the picture of an elderly female, comorbidities.
She had history of CHF.
Okay.
She was on. She
She was on home oxygen, but she had about 150 feet of tubes. If she was getting a liter out of the thing, I'd be surprised.
Okay.
On 3 liters.
Okay. So she's got some underlying medical issues. I'm sure she's on a couple different medications as well. Who has a
14 bottles on the kitchen.
all right. Who has a syncopal episode while on the can. Yeah. All right. So what's our differential? What are we thinking about? What could be going on? Good. So common things are common, right? Little old lady gets up. Is this daytime, nighttime? Gets up out of bed. Go to the bathroom in the morning. Oh, all right. Well, not. But wanders over to the bathroom, sits down on the toilet. Maybe doesn't have a super elevated blood pressure to begin with, and bears down to go to the bathroom. Get that vasovagal episode, drop that blood pressure. Really common. We see it a fair amount. I often work the 4 a.m. to noon shift here, and we see it at night all the time, right? You're kind of sleepy, you're tired, you get up out of bed, you're really relaxed, your blood pressure's kind of low, you shuffle over to the toilet, you go to the bathroom, you go out. It's not an uncommon thing that we see. So vasovagal, sure. What else? Yeah, I guess so, right? Certainly could be.
She was warm to the touch.
Okay, so she seemed to be.
It was hard to tell because gloves don't help very much in figuring that out.
Yeah. Were there? So you said she was bradycardic. Blood pressure?
Blood pressure was. We did take it. It was actually a little bit elevated.
Okay.
So she had was bradycardic a little bit higher, like 150s.
Okay.
But bradycardia was normal for her.
Mm-hmm. How bradycardic? You said 50s?
50s, yeah.
Okay.
High 50s.
All right. So, other things that can contribute to other things. So sepsis. We said sepsis. We said vasovagal. Sure. So hypoxia can lead to it. Right. She's got CHF. Is she fluid overload at this point? She's in some pulmonary edema.
No lungs, no bad lungs.
All right. So good. So on your differential, a lot of things on your differential you can cross off just with your history and physical alone. Doesn't take fancy tests to listen to the lungs and say that they're not full of fluid. That's not what's going on. Great. Somebody said something.
Dehydration, maybe?
Good. So is her blood pressure a little bit lower for whatever reason? She dehydrated because she hasn't been eating well because she had the GI bug the last couple of days. Is it the middle of July and she hasn't been taking enough fluids in and it's quite hot out? All those things can play a role with a reason why her blood pressure might have transiently dropped and why she's awake again. Could it be a pure cardiac event? Sure, right? Did she have any arrhythmia? She's got a 90-some-odd-year-old heart with a history of CHF. Why do CHFers get defibrillators implanted? Because they have arrhythmias, right? The bigger and floppier the heart gets, the more likely it is to go into a fatal arrhythmia. So that's why they get defibrillators implanted. So those CHFers that pass out, you worry about, even if they're back to normal now. So grab your EKG and be ready for the next one. Something intracranial? Sure, right? Hemorrhagic stroke. I guess, again, we talked a little bit about ischemic stroke. Could be something of that nature. Yeah, sounds like all good things. So transport was essentially unremarkable. To RED, gets evaluated in RED. And it sounds like she hits the door. She looks pretty much like you described. She's awake, she's alert. She really doesn't have a whole lot of complaints right now. Sounds like she's kind of at her baseline state of health when we see her and compared to her records in our hospital. Most of her workup, her EKG is pretty unremarkable. Her blood work looks pretty good. She's no longer either orthostatic or hypotensive. She's mildly hypertensive, as you mentioned. But they noticed that her heart rate is kind of low, in the 50s. So if you see bradycardia, a couple things that you kind of think about, but what are some of the things you think about? What are some things that may be running through your head? Causes of bradycardia.
Overdose.
Good. Who said overdose? Great. So could be medication, right? Did we do something wrong? Did she do something wrong? Did she take too many of her meds, get her pills mixed up? Many of these drugs get cleared either by the kidneys, by the liver, And so, right, so if she dehydrated or her kidney's not working well, did her, her beta blocker or calcium channel blocker build up a little bit in her system beyond what it should be? Is she extra bradycardic because of that? And did that contribute to her syncope? Yeah. You said?
SA node shut down.
Yeah, sure. Right. So, is it an intrinsic electrical issue with the heart? So, is she in a second degree or a third degree heart block? Is that why she's bradycardic? Very much so. Is she AFib with a slow ventricular response? We can happen, right? We typically see AFib with fast or rapid ventricular response. You can actually have the reverse as well. So, because of her bradycardia, she was actually found, she was on metoprolol, so a beta blocker, 50 milligrams a day. And that's a common medication for heart patients, for ischemic heart patients, like patients that have stents and heart attacks in the past, as well as CHF patients. CHF patients are often on another beta blockers. I mean, when they're on, it's a real common one for CHFers, and it has less of a heart rate slowing effect, but it can still happen. Carvedilol, you'll see that on their med list also. And so too much or those medications can certainly kind of contribute to that. So with her syncope and her bradycardia, she actually ended up getting admitted as well, and she's being evaluated for that. Sometimes they're just bradycardic for no good reason. You can have something called like a sick sinus syndrome. There's a lot of reasons why you may be primarily bradycardic. And if you are and it's causing syncope or inability to maintain blood pressure and causing issues, what happens to those patients? What do they get? Pacemaker. Yep. Perfect. All right. Any other cases? All right, then I got a couple. These cases are from multiple different agencies. They're de-identified. And again, protected for the sake of the innocent. All righty, so first case, 47-year-old male fall from approximately 15 feet. This was a, so I'll kind of give you a little bit of the case. So you're dispatched for essentially that. Fall with complaint of ankle pain. What do you want to know? I wasn't gonna lay you out there, Eric, but if
First off, you should put a collar on this guy. No, this guy, actually Todd and I are on this. He was doing construction at the new Quail Hollow, which is in West Lev. He was on like the top deck of a first floor, so about 15 feet. It's probably the max. Leaned up against the railing, which wasn't secure. We don't know what the deal was. He wasn't saying. We weren't asking, but he pitched off there, landed on ice basically on his ankles. And
Great.
he's an EMT for an agency, not around here, but he sort of knew what was going on. He said both his ankles were angulated, and he was pretty sure they were fractured, which I agreed with. He was lying there. They covered him with boards. He really had no.
with boards?
Well, they had like sawhorses and covered him with like
Oh.
plywood and stuff. So it was.
Oh, because there's snowing out. Yeah. Just throwing wood on the poor guy.
Just getting ready for the box.
Yeah, yeah.
But his main concern was his ankles were broken and that one of us was a paramedic because he wanted pain medicine, which was legitimate, I think.
Yeah.
He also was complaining of some lower back pain and like a secondary wrist injury that he wasn't as concerned about. But he claimed he landed on his feet, never hit his head, lost consciousness, anything like that.
Great.
Pretty straightforward otherwise.
So questions, what do people want to know? You can ask her. Anything else? Paints a pretty good picture. So you got bilateral ankle injuries. You have.
Suspect he's going to have a compression fracture of a spine, possibly.
Okay, could be. So building that differential. So you got potential, well, obvious ankle injuries, potential spine injury, potential wrist injury.
Just by mechanism of injury alone and the fact that he's got distracting injuries, you can't clear his spine, right?
Good, right. So we're thinking about kind of the evaluation of the spine and the trauma patients. Are distracting injuries, yes or no?
He's asking for pain meds. I'm thinking they're distracting.
Yeah, and you're going to narc them up too. For this guy, and Eric probably didn't do justice to this guy's ankles. His legs were like, his feet were kind of turned very much the wrong way. It was quite impressive. Quite impressive.
He was actually impressively not concerned. He was just talking to us, said those are broken, but it wasn't like he was screaming in pain.
Yeah.
He almost like tricked us into like those are clearly broken. Why are you not screaming at us?
Yeah, I was going to say, reading the report, he rated his pain as a 5 out of 10, which.
He said he's pretty good with pain.
Yeah. we had him screaming later. Don't worry. All right.
The question would have been, was he under the influence?
No, they weren't like totally emulated. It was clearly emulated.
Okay. Yeah. So asking him if he's taken other things. Yeah. Sure. I'm sorry. I'm describing it a little bit more. Yeah. So did he say he was on any other meds?
Straighten and just they were emulated enough that we had to like sort of straighten them, but it wasn't like full traction. It was just they had to go straight to get the spleen.
So most fractures you don't need to straighten. What would be an indication to try to reduce a fracture? What would be really the only indication for pre-hospital to reduce a fracture? Right. Yeah. So and did you have good pulses? Yeah, you had good pulses. You had good pulses. It sounds like both before splinting and after splinting. Thank you for documenting that, as well as in the emergency department when we arrived. We also had palpable pulses. Color wasn't great, but it's cold out. This guy doesn't have any boots on anymore, but he had strong pulses. So did we go yanking on his ankles right away? No. He stayed like that for a little while, right? So the difficulty with injuries like this is they're impressive to look at. They draw our attention. But his bilateral ankle fractures or lower extremity fractures are not going to kill him right now. What's going to kill him is the other missed injury that you're kind of glossing over because you're very much focused on the sexy injury a little bit, somewhere else. So sometimes those really graphic injuries are not the ones that you should be worrying the most about. That was not the case in this patient. So good. So yes, back to the spine issue. I'd say that this is likely a distracting injury, and a pretty good mechanism too to kind of at least make you have to kind of think about assessing this guy.
Well, he's in the height range for calling darts, so more than twice. It's 3 times the height. So he needed another 3 feet of balcony before.
Yeah, I think I don't like mechanism for most things as an indication to do something or to consult or to call. It should just raise your suspicion that you're at a higher likelihood of having more significant injury that way. Good. Other questions you want to ask this guy? Anything more about his history? He has. He's broken his hips. Guess how he broke his hips? Falling at work while working construction. Yes. He doesn't have good luck. Yeah.
He lied to us then. We asked, he said never ridden an ambulance, never been hurt at work before.
I talked to his wife, and his wife did he tell you he broke his hips too?
No.
Yeah.
And we asked him that specifically.
City of 11 year though, actually.
No, I wasn't.
We looked like hillbillies.
I heard another comment. So other questions? Past medical history, is that important for this guy?
Any drugs on board? Construction site.
Yeah, sure.
Yeah, did a medical event precipitate?
Good, right? So anytime you're dealing with a fall, and we see lots of falls, right? It's certainly now in the winter. The slip and fall on the ice is a super common call that we will get in the presentation that we'll see in the emergency department. Think about it. Is this just a purely mechanical fall? If so, great. But ask the questions. Did you get dizzy? Were you short of breath? Did you just walk up, climb up the ladder to get to the scaffolding and were dizzy because you just had your MI and that's why you fell? Or is it truly I tripped up the curb walking into the house type of thing? So ask the question, think about it. Is there a medical event that led to this trauma? If it's not, clearly not, and it sounds very much like this case was not, then great, move on and don't worry about that. But certainly for your little old, and think about it again, for your little old ladies, your elderly patients, kind of focus in a little bit more about what led up to the actual fall. Were you dizzy? Did you just get up from going to the bathroom? Is that what was going on? Do you remember slipping? If you don't remember a thing, it changes things a little bit, right? So the middle of the summer, the dude that just wakes up on the ground after walking in with his groceries from his car, sure, he could have tripped and just fallen and hit his head, and that's what happened. He doesn't really remember the event. But without him telling us that, and if he's 80 years old, guess what? He's going to get admitted, and there's going to be concern for syncope. And his workup is going to be very different than if he said, clearly, I tripped over the root on my driveway, and I fell. I just couldn't get up. One of those patients is going to get an X-ray, maybe a CAT scan, and if there's nothing's broken or whatnot, he's going to go home. The other one that had the potential syncopal event is going to get blood work, is going to get an EKG, maybe a CAT scan, and admitted to the hospital. It's a different workup. So thinking medical versus trauma as the medical versus mechanical as the inciting event leading to the trauma has to be on your radar. Was he on any medications? You remember? Yeah, it was diabetic, I remember that. So trauma patients, medications that I ask every trauma patient that rolls through the door, are you on, are you on any blood thinners, or any Plavix, aspirin, Coumadin? I always ask it, right, they're more likely to bleed. You want to know it, and you want to know it a little bit early because you may need to reverse something or give them a blood product. So ask those questions. Good. Your assessment. So we already talked about kind of angulated bilateral distal lower extremities with good palpable pulses. He had sensation for us. I'm assuming he had sensation for you as well. Anything else on your exam?
We sort of tried to ignore the lower part and just went head to toe and found out it was going down as far as like no breathing difficulty, no obvious chest problems. His abdomen was pretty normal and remarkable.
Yeah.
He had no other real complaints.
Good. And that's perfect. And actually, your documentation was very good. You went, like you said, you went kind of head to toe in your documentation. The HENT exam was unremarkable. Chest was clear, non-tender, belly was soft. You talked about each part. My trauma exam and your trauma exam should not differ whether you're dealing with a minor MVC or the GSW with 5 holes in his chest. It's the same all the time, all right? ABCs first and foremost, any significant external hemorrhaging, and then start head to toe. So up in the head, look in the eyes, extraocular movements, how does the face look, swelling, the jaw, any malocclusion or deviation of it? Does the midface seem stable? Do you have any bleeding or fluid coming out of any orifice of the head? How does the scalp look? Is it big and boggy? Do you have any big significant lacerations, depressions? Palpate around. Down to the neck, JVD, tracheal deviation, seatbelt signs, other signs of penetrating trauma or whatnot in the neck. Lung sounds. Please listen to lung sounds, right? You don't have the luxury of an X-ray or a CAT scan pre-hospitally. The only way you're going to diagnose a pneumothorax is if you listen to those lung sounds. So listen to your lung sounds. Look at that chest wall excursion. Palpate the chest wall. Push on bellies. Trauma and medical patients push on bellies. This guy did not have any belly pain. He very well could have had belly pain, could have had a significant intra-abdominal injury given the mechanism. And so it was well documented. No belly pain, no tenderness to palpation. Pelvis. Assess pelvises, right? How do we assess for stability of a pelvis? So you're going to try to close it first? You're going to push down first? What are you going to do with it? Does it matter? You'll see people do it differently. I think it maybe does matter. I think there's some maybe style points here. So what do we worry about with pelvic fractures? Yeah, right. So how does that happen? Yeah, very good, right? So your pelvis is a ring. And it's lined with a ton of, like a big venous plexus, if you will. As you fracture as you fracture that pelvis, you cause significant bleeding down there. You can bleed like stink and die from pelvic fractures. People do quite routinely. And so they're very hard to get. You can't get direct pressure on that bleeding very easily. Even in the operating room, it's very difficult to do. And so how do we do it? Well, we try to essentially kind of tampen out that bleeding on its own. So if you take that closed ring and you fracture it, one of the ways it can fracture is essentially it opens up. What you'll hear is called an open book fracture. There's depending on what classification system you look at, there's 3 or 4 different types of fractures with a couple different subtypes of fractures. It really doesn't matter. But if you have an open book fracture or a pelvis that is unstable and widened, you've now taken the volume of a smaller sphere and made it much larger. And so you can fill that much larger space up with much more blood, and that's a bad thing in a trauma patient. So the idea is you want to bring it back to anatomic alignment to close it up again to decrease the amount of space that needs to fill up with that blood before it will start to tampen out itself within the pelvis. That's why we close it. It hopefully decreases the bleeding because it increases the ability of the blood that's already there to start to kind of compress the bleeding and slow it down and or stop it. So what you'll see a lot of patients, a lot of people do as they're kind of evaluating the trauma patient, they're listening to the lungs, they're pushing on the belly, and they're assessing the pelvis. A lot of times they'll kind of push down and start to rock it. You can do that, and you'll know if it's unstable that way, but if you do have an open a pelvic fracture, you can make it worse before you make it better. Instead of pushing down first, I essentially try to close it first. If it's unstable and open, you'll know it when you close it. Who's felt an unstable pelvis? It's, until you feel one, you're like, I wonder if I'm ever feeling it. Then you feel one, you're like, oh, this is what it feels like. And you won't forget. So was that how you describe it? Yeah, it's there, and it hurts like hell. If the patient is awake, they're going to tell you too. So I essentially try to close it to begin with, and I have movement, and I find that unstable pelvis. Well, great, you've now already done the therapy for it, and you can then immobilize it. What do people have to immobilize pelvises or stabilize them? What? You got the SAM. Not bad. Other things? Sheet. Yep. Anybody have the T-pod? It's a little bit more expensive than the SAM. I think it works a little bit better. It's a little bit easier to use. It doesn't really matter what you use, but in some way you need to apply traction to close that pelvis. So if you take a sheet, kind of fold it to about fold it over itself a couple times to about a foot or a little bit less than a foot in diameter, and you wrap it along that pelvis, apply traction, and then clamp it down on either end. That can do the job. The SAM will do it. The T-pod is kind of essentially like that sheet with a wacky pulley system. You pull kind of the center thing that kind of brings it in. The important part is, where do you place this? Where do you want this pressure to be applied to the pelvis to close it? Because you can make things significantly worse by putting it on wrong.
Below the iliac crest.
I'm sorry?
Right below the iliac crest.
But I would say definitely below the iliac crest. But where? A lot of people will think, oh, here are my hips. Here are my hip bones. That's where I place it. What will happen is your pelvis is kind of this ring, right? You got your iliac crests.
There's a whole one over there.
Ah, look at that. If you have an open book fracture, you often kind of have a fracture and disruption of the pubis symphysis here. So this is widened down in this direction. I apologize if people can't see. If you apply that pressure up here, what's going to happen to the bottom? It's going to splay right out. You will make things significantly worse. Where you actually want to apply the traction is essentially over the greater tuberosities. It's much lower. It's kind of more like over your hips, if you will, versus over your pelvis. And that's where you want to focus and center whatever device you're utilizing. It's that far down. Good. All right. What, you couldn't? That's better than this. Come on. Good. And then extremity injuries, right? Trauma is easy. You push on it. If it hurts, image it. Do something with it. Exactly. All right. So interventions. Did you do anything else? Intervention, or either.
We tried to scoop this guy in a scoop stretcher before splinting him, and he was having none of that because his both ankles were real floppy. So we ended up, he said, "I'm fine here. Why don't you splint those first?" Which we said, "Okay, that's a good idea." Because he was kind of under the weather, and that worked a lot better because they were much more stable.
Yeah, I think that's.
He was back in sports and a scoop, and he was pretty stable to lift on. And there were like 400 construction workers to help us lift him up. So.
Perfect.
So here, Tom, is my point about the thing about the distracting injury. If you have somebody who is this calm, this cooperative, this participatory in his care, you can hardly call those a distracting injury. I think that somebody who's, writhing around in pain, something like that, you can absolutely say, pretty clearly, yeah, that's gnarly to me, clearly it's gnarly to them. But somebody who's that cooperative, participating in their care, offering suggestions on how to proceed, that is not somebody who's distracted by their injury. Not in my take.
So I will agree and disagree with you. So this guy's actually complained of back pain, though.
Right.
So you're done right there. The distracting side, so you're right? So what's distracting to one person is not necessarily distracting to somebody else. But our ability to clear somebody clinically is based on utilizing these decision-making tools and looking at our thousands and thousands of times of doing that and saying whether or not it worked or not. And if you look at the studies that these decision-making tools were based out of, distracting injury was left somewhat vague, but they actually gave specific examples. So the long bone fracture, which this guy doesn't have a long bone fracture, but the long bone fracture was considered a distracting injury for the Nexus study. So you can argue the same thing, right? I got a dude that fell down. He's got an isolated femur fracture. He seems very calm, collective. He's participating. He has no other complaints. Can I clear him clinically? You'll have some people say that all the evidence will say that these rules were never applied to him in the studies that proved we could do it clinically. And so we really don't know whether you can do it clinically or not. So,
it turns out he didn't have a broken neck.
What's that?
It turns out he didn't have a broken neck.
This guy? He had a broken spine.
Yeah, a lower, that a collar was going to do nothing for him.
Yes, agreed. That being said, he was in a collar throughout his stay until the very next day, so he had a lower spine. So this guy came in, and actually, we'll get back to that in a second. How about that? So, right ankle. That's bad. That's the lateral, right? So you got multiple broken bones, tibia, fibula. This is what we consider the mortise of the ankle, right? The kind of building block of the ankle where the tibia sits. This is a fracture known as a pilon fracture. This kind of crushes that whole ankle joint itself. These are very significant fractures. And guess what was on the left side? Essentially the same fracture, another pilon fracture. These fractures are very difficult to deal with. They often have long, complicated roads in the future. And so this is not a happy day for this guy. So he got X-rayed up. He got CAT scanned essentially from head to toe. Later on, once we kind of ruled out any other significant injuries that needed to be dealt with, he got sedated in the emergency department. His ankles got pulled on, reduced, splinted, and he. As of this morning, he hadn't gone to the OR yet, but he'll be going to the OR likely to get essentially X-fixes put on, right? Those kind of external skeletons with the pins going in to kind of hold everything in place. And he will have bilateral X-fixes on for quite some time. The rest is of evaluation, so he had some lower spine pain for complaint and for evaluation as well. This type of injury, this type of mechanism has a high concomitant rate of spinal injury with it, right? So the fall and the land on the feet, that axial load transmits that force all the way up the spine. And as you kind of go up the spine, the area that tends not to do the best with it, excuse me, as you go up the body, the area that tends not to do the best with it ends up being the spine. So it's not uncommon to have upper L spine, lower T spine fractures associated with this type of injury. So while it's less likely to have a C spine fracture, as soon as you tack on a fracture somewhere in the spine, you have a 10% chance of having a fracture somewhere else in the spine. So the very fact that he had lower back pain still raises his risk of having a C-spine injury, even if he doesn't have discomfort up there. So in my book, this guy still buys a collar. Remember, per protocol, we can't partially clear a spine. Right? You can't say he has neck pain only, so I can bring him in sitting up. And the same thing, he has lower back pain, so I don't need to do the collar. It's either he needs to be immobilized or he doesn't. And these days, immobilization is collar flat on the back, flat on the cot. Scoop stretcher was fine. That was great. And you kept him mid,
My intent wasn't that I cleared his spine. I just forgot to put a collar on.
Oh, and in the end, he came in essentially. He was kept midline. Yeah. So here's a quick cross section of his spine. This is anterior. This is posterior. L5, 4, 3, 2, 1. T 12, 11, 10, 9. Everybody see anything? It's not. It's slightly subtle.
Well, looks like compression of the right here.
Yeah.
Which one?
Right here. This is compression and this is distorted right there.
Two down,
Yeah, two down,
there's
the line, it's a little bit.
Yeah. Two down. So that's actually kind of that's spurring that happens with old age. Guess what? A lot of our spines here in this room will look somewhat like that. Okay. When you talk about spinal fractures and this type of fracture, again, a compression fracture is often the type of fracture that you have. So L5, 4, 3, 2, 1. Look at 1, right? When you assess for compression, what we often do is essentially the posterior height should be very similar to the anterior height. So that's pretty equal to that. That's pretty equal to that. That height is different than that height, right? So he has an anterior compression fracture. You can see a little bit of kind of propulsion of the bone fragments there as well. And then it kind of extends at least the anterior half of that vertebrae. The nice thing is it really doesn't involve the posterior column. And what you can often see is as you crush that vertebrae, right, the bone's got to go somewhere, so it splays out the sides, and you can get retropulsion of the fragments. If the fragments go forward, you really don't care. There's not necessarily a whole lot there that's worrisome. What lives right there? That's your cord, right? That's where you get the retropulsion with cord impingement, and that's where you end up with neurologic issues. This guy had no neurologic issues, luckily, and there likely won't be a whole lot to be done for this. It's mostly kind of pain control brace, and they tend to do okay in the long run. Sometimes people will inject cement in there if they continue to have significant pain in the future. So in the end, no other injuries were found on this guy. He ended up with a wrist splint as well because he hurt there, but the x-ray was not conclusive. His knee was a bit swollen, so we think he might have jacked up something from a ligament standpoint, but that won't be fully known until likely an MRI down the line. And his post-OR films will be impressive to see all the hardware that ends up in there. This guy's got a long, hard road in front of him, unfortunately.
Yeah, I mean, he's not gonna, this is somebody who's gonna have a real difficult time continuing his occupation.
This is somebody, yeah, I mean, he's leaving the hospital in weeks in a wheelchair, not to walk for quite a long time. And so, yeah, he's 47 years old, diabetic with these injuries. He may never be a construction worker again. We're kind of over on time, but if people want to hang out, I'm happy to talk. If not, it's totally up to you guys. Good with pain control, right? Give him pain control. This guy, he had significant pain. He had significant injuries. I saw that you chose morphine, Eric. Any reason why morphine over fentanyl?
He chose morphine, actually.
Okay.
Yeah, that was the first time I've given him.
Okay. I,
He knew the dose.
6 one, half dozen another. Yeah.
He just pointed out he wasn't a recreational user.
I think it's fine. In general, I think most of us around here tend to use, and you as well, tend to use fentanyl for most things, including trauma. It has a couple added benefits for the trauma patient. It's less likely to cause hypotension, the biggest benefit of it. Also, people tend to be a little bit less allergic to it and tend to have less histamine release, less itching, less nausea with it versus morphine. So that was interesting. That explains it then. He was mildly hypotensive for you guys. And his blood pressure for us also kind of went anywhere from 100 to 140 throughout his stay. That was kind of just him, though. He was not hypovolemic. He was not shocky in any way. His lactate was fine when he hit the door. So, not necessarily what I would expect for a 47-year-old diabetic dude, but it is what it is. So, all right. People want to take off? All right. I will pause here. And I will be around to talk more, or we can kind of call it an evening if you guys like. So thank you all for your attention. If you guys need to take off, I know that you have drives and it is late already. And you won't hurt my feelings for leaving. I get to go home too, yeah.
Thank you.
Thank you very much. Andy, the other thing I would say about the spine would be, again, if you have a suspicion for elsewhere, not only do we not clinically clear spines, that you end up with a CAT scan of your whole spine, whether you hurt or not, as soon as you find one fracture.
I just think that it's worthy of more study because I think at the end of the day, down the backboards and collars, we're going to be able, I think that we will probably find that people who are calm, cooperative, and able to isolate these things will probably be able to help us further narrow their injury.
I think you're.
These are people that we used to fly. We used to put the helicopter
Yeah.
flying out loud, and that's just,
Yeah, I think you're absolutely right. The hardest part of that is how do you standardize it so everybody does, again, what's distracting to one is not to another.
I think that part of that is, just good experience.
Yeah.
Those cases where the people are like that are few and far between.
Yeah.
But they do exist.
No, yep. I agree. And in the end, right, like what I always say is, if what you did was right, you can do whatever you want in medicine as long as you're right.
I mean, this guy, I don't know, but I mean, it sounds like from the context of somebody who was fall and had injuries that were obviously distracting to us, but was not. This person was not. When you look at that person in context, you're like, okay.
Yeah. Well.
He's got it together. He's not bringing it out. He's telling us how he'd like to be treated. I mean, I might have in the past taken care of, physicians who had, what were otherwise, distracting injuries, but they, when they say this is what it is, I know that's it. I can tell. You got to have some level of. I think I was ready.
I'm sorry. Sure. Go ahead.
Painful.
Yeah.
Because when I was at the first aid station, we had a young man come in, which Grafton ended up transporting. And he came in, he had gone off a jump, he had landed wrong, he fell over on his side really hurt, and we just kept him for a while, checking him. He was, kind of low, and he was sitting there. Pain, it's warm. My hip hurts a lot. It doesn't really hurt stuff. And brother's going to take him home, so another ski patroller, help him stand up. His knees go down. He turns white. Let's lay him back down.
Yeah.
Blood pressure goes back up. Just the one. I said, I don't care. There's something wrong with him.
Yeah.
His mother called up and afterwards and said he had broken pelvis.
Yeah. Yeah. I mean, it depends where you break it, right? So lots of people will break it, essentially an isolated pubic rami, one of these down here. And you don't really care about those. They actually don't cause any issues.
Don't know where he broke it.
Yeah.
Just that he did.
And
Something wrong with him. And I just said,
yeah.
I think it's a broken pelvis.
I didn't take any intervention on him because his BP, even though it was slightly high at 138, his pulse was in the 80s. And I said, he's a young kid, but maybe he should be lower. But it's like, he's not in any pain. His feet were a little cold. We warmed those up. That's all we did for the 40-some-odd minute ride.
Yeah. Did you have something?
Well, I think this is mine. We don't have to go through the whole thing, but
Yeah, sure. This is a great case.
yeah.
This is the TCA overdose. Yeah. So
What's that? Did you call? Did I call? Or
what, poison control or?
oh no, I didn't.
No, yeah. You don't need to call. I think Vermont makes you call. New Hampshire, Vermont makes you call for adenosine.
What was the
For bagel, yeah, it was
just for the record.
Yeah.
Figured that out the hard way.
it was. What was the?
It was a 18-year-old intentional overdose of amitriptyline, 24 50 milligram tabs of amitriptyline. So you tend to see kind of, greater than a gram in an adult, average size adult is certainly within the toxic range. It sounds like when you got there, kind of conscious but altered or somnolent somewhat.
She was just crying and.
Okay.
If I remember right, she was actually alert-oriented, just crying.
Oh, all right. That sounds right. Tachycardic. If anything, a little hypertensive, though not hypotensive, like 130s, 150s, and then essentially an otherwise unremarkable physical exam.
Her T waves grow.
So I saw you mentioned that. So the thing with that is, so T waves are not actually what you're looking for in TCA overdoses. So peak T waves. We do think of peak T waves, and we do treat peak T waves at times with bicarb. It's not for TCA overdoses. Does everybody know what?
Test.
Yeah. So hyperkalemia actually is often what gives you your peak T waves. That's one of the initial signs of hyperkalemia and the indication to start to treat, perhaps with bicarb. What we tend to look for in a trigger to treat for TCA overdose is your QRS. Is QRS widening. Okay, so what you'll see, and I'm not positive, you may end up with some peak T waves with that, but it's...
They were growing.
Yeah, that may be a manifestation of her significant tachycardia as well, but her initial QRS, so I didn't have an EKG from you in the field. Our first one here shows her QRS to be 104. So the protocol, I believe, reads, and which is what we would essentially do in the emergency department as well. So tachycardia with known or suspected TCA overdose and a QRS greater than 100, that's the indication to treat. You gave, I think you gave an amp of bicarb. So 1 to 2 amps of bicarb, or 1 to 2 milliequivalents per kilo. She was, I think you have her down as about 50.
She really, by protocol, would have taken 100.
Right. For New Hampshire protocol, you're right, it says 2. Vermont says 1 to 2. But 6 1/2 does another. So what would you actually you'll give your initial slug, and then ultimately you end up on a bicarb drip. You take like a D5W bag, you throw 3 amps of bicarb in that, and you start that at like 250 and run that. And so that does a couple things. So the way tricyclics work is there's sodium channel blockers. Sodium channels are kind of all over the place. Specifically, they're in the heart and your brain. That's why you see seizures and cardiac arrhythmias with TCA overdoses. And so the bicarb does 2 things. The alkalization helps clear the drug faster, and we say it's bicarb, right? But what's the full name of it?
Sodium.
It's sodium bicarb. So you actually give a huge slug of sodium when you give an AMPA bicarb, and that extra sodium helps overcome some of the blockade of the sodium channels and helps improve the sodium flux in and out of the cardiac cells, which helps with your dysrhythmia that you're going to end up. So what happens is, and you can actually see this real time, and I don't know if you did or not. Did you see any difference in your EKG pre and post bolus?
No, my bolus was pretty close to here, so I don't even remember if I took it out.
Sometimes if you're watching really closely, you can actually see the QRS narrowing as you're giving it. And one might have been a little light for her, maybe with the two. So I think we gave her another and started on the drip. And then she ends up going to the ICU to be monitored, remains otherwise pretty stable. Her next EKG, she gets as wide as 120, and her QTC also stretches out as far as 520. So widening QRS, prolonged QT, and the other thing that's really classic with TCA overdose is an R wave and AVR. Right, so normally AVR, you have essentially kind of like a big Q almost, and then an R, and then kind of a small R, and then this. If you have a prominent R in AVR, that is almost pathognomonic for this disease process, right? Look at her R waves and AVR and both of those. So this screams TCA overdose. All of these EKGs do. You did the appropriate treatment, and this is her EKG a day and a half later after being on bicarb. Her QRS came down to 94. Her QTC came back down to 440. This is essentially normal EKG.
So there weren't EKGs on the test? I know I did them. I was maybe I didn't scan
No. It was weird. I couldn't find a drop sheet in our system. I found the drop sheet scanned in Sepsis, and I found the vital summary, but I didn't find the EKG. And I only saw one attachment. Oftentimes it's multiple attachments, and maybe I'm getting it confused with another chart. But I looked for the pre-hospital EKG so I could show it.
I know I left one here, and I don't remember for sure that I scanned one.
Could be. So, good case.
Yeah, it was interesting.
Certainly a toxic dose.
Yeah. I looked it up on the way to the call because I wasn't sure.
Yeah.
We had an idea how many. I think they said.
I think they specifically said like 24.
Right,
Yeah.
and so,
it never made a whole lot of sense to me why you
You ever
give
tried to look
very
it up?
much a deadly drug to used for depression to really depressed patients.
How did she choose? Just she had it, or
I think she was on it. Yeah.
Yeah.
So
so she knew it was
You
a
can
good one
take
to
it
take.
for migraines too. That's
It
what
can-
it's more used for now, right?
These days, you'll see it like low doses of it for migraines. It gets used for a couple things. It still gets used a little bit for depression, but with the
Toxic.
popularity of and the efficacy of SSRIs, you see much in the lack of side effects compared to these. You don't see a whole lot of TCAs around anymore. You probably used to see TCAs.
Too many SSRIs don't do good for people either, though.
We've had
No,
cases
We've had
of
some
that.
really good cases of that.
Yeah, but they tend to die less though in the end. So
With if you call it a sodium channel blocker, it must be different than all the canes that we deal with that are also sodium channel blockers, right?
no, it works in somewhat the same way.
Really?
Yeah, that's why. I mean, right? So if you give too much lidocaine,
Same idea?
Yeah.
So if we ever accidentally overdose somebody on lidocaine, another bicarb could be, again, it's a sodium bolus. I'm just,
I don't think they're carrying it.
I don't think we're carrying
Yeah.
It's lidocaine dosed differently where it's just not, you're not gonna get to that toxic.
no, like if you so say you probably you could kill a kid with your lidocaine on board.
What, 3 milligrams per kilogram is your max dose of lidocaine, right? Something like that?
Yeah.
Something like that.
Yeah. So where you see issues, you tend not to see it a whole lot if you're giving a cardiac dose appropriately to a patient. Where you see it is a bozo like me, I'm trying to do a field block so I can do an IND, and I inject directly into a vein versus just the soft tissue because I didn't pull back on the needle first to make sure I wasn't in a blood vessel. And I dropped Right. I drop a bunch of Lido, 2% Lido, or Marcaine, something that's even has a much lower toxic threshold, 1 cc per kilo type of thing, right into a blood vessel. Or where you see it the most is with the anesthesiologist when they're doing regional nerve blocks. So you're going to have hand surgery and they're going to block your whole arm, and they hit you intravenously versus hitting the nerve appropriately. Those patients die quite quickly.
Notice that nerve blocks were safer.
Well, done appropriately, they are. The way we treat that actually is I'm sorry, I'm blanking here.
Sodium or?
No, lipid emulsion therapy. You essentially give them the fat that you would, like TPN, like intravenous nutrition, the lipid component, the fat component of that, you dump that into their intravascular volume, and it acts as a lipid sink for the drug and sucks it up. And so that is like the one thing that's actually been shown to actually help those patients even getting back once they've arrested. And it's getting used for lots of things now. The same way things like high-dose insulin is another thing that can be used for muscle. It's really strange mechanisms, but those crazy toxicologists figure this stuff out. I can't let that animals and trying to humans.
So important.
Yeah. Thank you, John.
Hey,
Thank you.
Thank you.
Yeah, I don't think any of the other. Oh, one of the other ones was yours too.
Was it the
Yeah,
cardiac arrest?
No, the aortic injury. That was you, right?
Yeah, that was Eric, I think, again, right?
Oh, jeez.
Yeah, cardiac aortic
The
injury.
broken arm and
Yeah.
then also had the
I
aortic.
put an
Yeah, yeah.
image of the broken arm up in this.
Did I actually get to it? This is an interesting case that would be good to talk about. That Hartford brought in. Sean probably told you about
Is
this.
this
Sepsis.
the mitral valve?
She was septic,
Septic from the mitral valve.
yeah, from endocarditis.
The one where the charge nurse told them he was
She's still
crazy?
here.
Most people die from that.
She
Melanie
so
was taking care of her about for a week.
this is her list of problems at this point.
Oh.
So she was an IV drug abuser. She was bacteremic from her endocarditis. She ended up with meningitis because she was throwing septic emboli to multiple places, including her brain. She had the endocarditis. She had the septic emboli and caused bleeds in her brain from it. She had the septic emboli go to her eye, her kidney, her spleen, her liver. She ended with a septic shoulder and went to the OR for a washout of her shoulder. She had a big abscess that developed on her hand because she threw an emboli to her hand that further really got infected. She's a month and a half into her hospital stay, 20 years old. She's still here.
This is the one where the charge nurse told Sean he was crazy when he's called it sepsis. I think so.
She's, yeah.
Drugs are bad. Drugs are bad.
Don't do drugs, stay in school.
This one's a 77-year-old MDC.
She hit the fire truck.
Yeah, that's right. Hit her park. Who's fire truck she hit?
Hartford's.
She told her husband to slow down.
And that was her wrist was certainly broken. And you didn't miss anything. She was stable here in the ED as well. And again, mechanism, good injury, may go to the OR type of thing, and the fact that trauma scans everybody. She gets a CAT scan, and she had some mild, little bit of chest pain she described, and later on she did describe a little back pain for us. But so look at that aorta, right? So this is kind of high up, right around here. This is the ascending aorta. This is the descending. So the arch is coming up and down, and we're gonna scroll down. So there's the arch. What do you see there in the descending aorta?
It's a split
Yeah, right.
right there at the top.
So-
Well,
This should be one circle.
That's,
See
so
that?
it's busted through a couple layers. That's where the idea is.
It's a big dissection flap. You can kind of follow it down, and it eventually rejoins.
Well, that's good.
But
Yeah.
man.
yeah, so and this is the classic injury, right? The sudden deceleration injury from significant speed. So remember, you have when you were born, and when you were in utero, you had that ductus arteriosus, that little duct that shunted blood from the right side of your heart to the left side of your heart. You shouldn't need your lungs when you're in utero. You're getting all your oxygen from the placenta. So the blood would kind of come in and shunt over to the left side, so it just kicks out to the baby's body. That closes off quite quickly after you're born, but it remains, you end up with this little kind of ligament there, essentially this connective tissue that still remains there, and it's in that area of the aorta, and what happens is when you have a deceleration injury, that tugs on the aorta, and you can either rupture or dissect the aorta.
What's the name of it after?
The ductus arteriosus.
Okay. But that's
So
not, I mean, that's, I mean, this is a, I mean, I guess this is a common injury, but this is not the, what's the instantly fatal one where the,
But this
tear
is
the top of it right off?
you just rupture it. You pull, so this dissected part of it, if you rupture all the way through.
It's just not your name of it once it becomes a ligament or something, or whatever they call it.
No, you're thinking of ligament of Treitz. That's the from your umbilical cord to your liver.
Yeah.
So good cases.
Yeah.
Good images.
Yes,
Yeah, and that's all blood around her.
We've had pretty high acuity for
This is all blood around here. She's got a little bit of a leak.
But that was non-operative and
Yeah.
watch her and send her home.
I don't know if vascular put a they might have stented it. Sometimes they put a graft in. It was non-operative. If anything, it was endovascular. But the descending ones, often you can manage medically, just with good blood pressure control.
Cool.
Yeah, we can encourage the.
So we're going to leave the Fed. We're going to
Perfect. Yeah, Joe was telling me. I think it's a good thing. Are you gonna totally drop dopamine?
Yeah.
What?
Why?
Are you gonna totally drop dopamine? Great.
There's no reason to, and if, provide her comfort or whatever, I'd rather they get something than nothing, and so, and choice is okay.
Yeah, if you're willing to
Unless
carry
there's some
on.
compelling reason to get rid of it.
It's still gonna, I mean, like you said, it's still gonna be that if atropine doesn't work, you can pick some random dopamine. Those are gonna be kind of that'll still be the AHA's frontline recommendation, but I believe the state's moving Fed up on recommendations for
Yeah, no, if you're willing to carry both, great. I think it's awesome.
and for
As long as you
sepsis.
keep giving it to us for free.
Right?
Don't knock that book, yeah.
Yeah, exactly.
Thanks, guys.
And that's a good thing.
Thank you.
Thank you.
See you tomorrow?
Yeah, I'll be fine.
Later, you're gonna go home and sleep a little bit?
I don't know, we'll see. My wife was sick for the last 2 days, and it's just been in a